Assalamu alaikum students. So this is part 2 of the acid-base physiology lecture series, and in this we'll be looking at how to diagnose simple acid-base disorders. Um, and in this respect, there are some terms that you need to be comfortable with. So when in this context we mention the word metabolic or respiratory, basically what we mean by metabolic acid-base disorder is that it has to do with the function of the kidney primarily and not the respiration. Okay, so the kidney is at the center of this disorder when we use this word metabolic, and it's usually the bicarbonate ion or the hydrogen ion. Okay, the respiratory word is self-explanatory. The acid-base issue is with the respiratory system. Okay, so that's these are two terms, important terms that we'll be using extensively from this lecture and through to the third lecture. The word compensation basically means that whatever original insult was done to the pH, the acid-base balance of the body, the other system, which was not the culprit, will try to compensate what the culprit did. Okay, you will understand this further when I explain this. The acid-base compensation rule is, for example, if kidney is at fault and due to some problem with the kidneys managing of hydrogen and bicarbine, the acid-base balance has been disturbed. The compensation will come from respiratory system. This is the rule. Okay, so if kidney malfunctions, respiration comes to its rescue, and if respiration malfunctions, the kidney comes to its rescue. Okay, this is that general rule of thumb. Now, let's go into diagnosis. So first, we'll look at how does acidosis get sorted out in the clinical setting. This is part of a wider diagram. I will show you the complete diagram on the third slide from now. It looks a bit busy, even scary. So I have sort of dissected it into two halves. This half is to do with acidosis, while this half is deals with alkalosis. Let's first look at acidosis. So you get the arterial sample. You look at the first thing you look at is the pH. Okay, the pH is in this case less than 7.4. Obviously, this is an acidosis. Okay. Now, which type of acidosis is it? Is it metabolic acidosis or is it respiratory acidosis? So the second thing that you will see is you will see the bicarbonate concentration. If it's less than 24 milliequivalents per liter, 24 being normal, if it's less than that, then what you will infer from this is that it is basically a metabolic disorder, because to keep the bicarb intact, whose responsibility is it? It's the kidney's responsibility. Okay, so if it's turning out to be less than normal in a acidotic patient, then this must be mainly the kidney's fault, and hence you label the person as metabolic acidosis. Metabolic acidosis. Okay, pH less than 7.4, bicarbonate less than normal, metabolic acidosis. Okay, then you look at PCO2. If PCO2 is less than 40 mmHg, 40 mmHg obviously is the normal PCO2. Okay, and if it's less than 40, then you say that this is basically respiratory compensation has been done on this metabolic acidosis. The rule of thumb has been applied. So original issue was due to the decrease in bicarbonate. The kidney was identified as the main culprit, and we know the rule of thumb: when the kidney is the culprit, respiration comes to the rescue, and it tries to exhale more carbon dioxide than usual, which decreases the PCO2 in blood, which basically is a clue that respiration tried to exhale more carbon dioxide than normal, hence decreasing its PCO2 lesser than 40, trying to exhale carbon dioxide so that the decrease in pH due to kidney is somehow mitigated. Of course, compensation, as the word in English means, is not repayment to the full. It's just compensation. Okay, so the whole insult to the pH may not be addressed by respiration, but still something is better than nothing, right? And this basically is a rough formula. I'm not very happy with the figures here. I'll be showing you another, a better table. But let me just explain this a bit here. So 1.2 mmHg decrease in PCO2 for every 1 milliequal per liter drop in bicarbonate. This is a way to quantify how much compensation do you expect in your metabolic acidosis. So, said simply, each 1 milliequivalent per liter drop in bicarbonate should be compensated by a drop in of a drop of 1.2 mmHg PCO2, i.e., this much carbon dioxide needs to be exhaled out to bring the pH down upwards towards normality. So this is quantifying your compensation. If you don't remember this, it's not a huge issue at this point in time. However, when you actually start nephrology, you'll be dealing with these figures a lot. Okay, so this is this wing of this this algorithm. The other is if your acidotic patient is found to be, when you looked at the bicarb actually came more than 24. So you obviously first then look at PCO2. If PCO2 is more than 40, so it's really the mirror image of what is happening on this side. The PCO2 is more, you say, so this must be respiratory acidosis because PCO2 is more than 40, more carbon dioxide is circulating in this patient, which means that the pH increase is due to actually carbon dioxide, excessive carbon dioxide, which is the case here. And to compensate, if respiration is the culprit, what is the rule of thumb? The compensation will come from the kidney. Okay, and what should the kidney do? The kidney should basically increase, because it's acidosis, the kidney should increase the bicarbonate to fight this acidosis. Okay, and this is a calculation of how much bicarbonate needs to go up for what unit of increase in PCO2. As I said, I'm not happy with this because he mentions 10 mmHg increase in PCO2, although it's from a very reputed book. Still, I think it's difficult for you guys to remember this stat. I'll give you a much more easier stat to remember. For now, it suffices that renal compensation is the appropriate compensation for this type of acid-base disorder. So we've done two types of acidosis, metabolic acidosis and respiratory acidosis, and we've looked at respective compensation in both disorders. Now we look at the alkalosis, same sample, but the pH came out to be 7.4. So we immediately turned our attention to alkalosis. Of course, above 7.4 is alkalosis. Which type of alkalosis, you can almost predict now what I'm going to say. If you look at the bicarbonate, obviously now it's alkalosis, isn't it? So you look at the bicarbonate and it's more than 24, which means that kidney is not doing its job, because again, bicarbonate is kidney's job, kidney's headache. You label the person as a metabolic alkalosis patient. Then you look at the PCO2 because of the rule of thumb. It's in metabolic, the respiration should be compensating, and in alkalosis, the respiration should be conserving carbon dioxide, and it should come out to be more than 40 mmHg, so that it addresses alkalosis. Okay, because carbon dioxide being an acid, it fights the alkalosis, and this is the stat. This amount of PCO2 needs to rise up for each 1 milliequivalent per liter rise in bicarbonate. Okay, the last thing is if alkalosis is of the respiratory type, you will find that the PCO2 is actually less than 40 mmHg, and hence carbon dioxide is on the lower side, and it's causing alkalosis to be present. Remember, hysterical breathing, say before a difficult viva, leads to respiratory alkalosis, overbreathing. You blow off extra carbon dioxide, you drop it below 40, you enter into respiratory alkalosis, which, by the way, depresses the CNS and so on and so forth. So please don't do that. Try to not do that. Try to prepare things in time. And the compensation comes from renal. And what do you want renal to do? To get basically rid of extra bicarb so that you address the alkalosis. Okay. Now you are ready to look at the entire algorithm, and this is it. Okay. Now it's not very scary, is it? So this is the entire thing. Uh, it does look busy, but it's a very nice diagram to go through the stepwise approach of actually diagnosing in the clinical setting. Okay. So once again, just to sum up, look at the pH, look at the bicarb, look at the PCO2, and you are good to go. Okay. So this is basically the chart that the table that I wanted you to sort of retain. It's easier. It gives you values according to 1 milliequivalent per liter and 1 mmHg. So it's much more simpler. So let's sort out metabolic acidosis first. By the way, metabolic acidosis is the most frequent acid-base disorder that you'll encounter, that you're likely to encounter in the clinical setting. And one reason for that is because diabetes is such a prevalent disease, unfortunately. And in diabetes, one of the complications is diabetic ketoacidosis, which is the metabolic acidosis of diabetes. Okay, and since diabetes is common, hence this particular acid-base disorder is very common. So that's why metabolic acidosis is something that you need to have some very, very clear concepts about. So the primary disturbance is again bicarbonate. It's decreased. Compensation should be by decreasing PCO2, i.e. exhaling more, and the predicted compensatory response, that i.e. the quantification. This is now nice. 1 milliequivalents per liter decrease of bicarb needs to be translated into 1.3 mmHg decrease in PCO2. So this is a nice way of remembering this. 1 milliequal, 1 unit of bicarb, 1.3 unit of PCO2. Okay. Similarly, in alkalosis, we've done this. One unit of bicarb, 0.7 increase in PCO2. Okay. The second reason of selecting this table is that it actually divides the respiratory acidosis and alkalosis into acute and chronic. And in this, all you need to see is this here, the units. So in acute, you get by increasing zero point 0.1 milliequal, zero point 0.1 unit of bicarbonate, while in chronic respiratory alkalosis, you need to rack that up by about 0.4, and then you can address your increase in corresponding PCO2. This is respiratory acidosis of the chronic variety. Similarly, respiratory alkalosis, acute and chronic, just look at these values and you are good to go. And remember, in the acute, you get by a smaller value of correction, while in chronic, you need a bit more. Okay. Now this is a practice, two practice cases. These are the normal ranges. You can see the pH, you can see the bicarb. The average is 24. PCO2, this is the range. The average is 40. Now, if you can work this out and then this out, okay? Um, Basically, let me work this out for you. pH is 7.35. So it is basically, we are looking at a acidosis. Then bicarbonate is 16, average is 24. So bicarb is quite low. So this is metabolic acidosis, okay? And PCO2 is 30 instead of its average of 40. So this is a appropriate compensation. So this basically is a case of metabolic acidosis with appropriate respiratory compensation. However, you want to solve this out and let me know what you find out. This is a massive acidosis, and you see the bicarb massively decreased. However, you see the PCO2 has risen, not decreased. What is that? What could it be? Okay, so this is your homework. I'll be, as usual, looking into perusing the comment section below. It's not a very busy section as far as your class is concerned, which is not good. These are things that need to be applied and solved and discussed. That's why I leave blanks like these, so that you can use your head and come up with answers. Okay, so expect that. Okay, so this is probably the final slide in this particular lecture. Lecture 3 should follow it. So the values, basically this is a acid-base map. You will find these in nephrology wards all around the world. And basically what happens is you can see the x-axis, there's bicarbonate, and you can see the y-axis, so PCO2. So obviously the the compensations are plotted on the x and the y-axis, and then you have the pH. You have all of these lines of varying pH from the most acidotic to the most alkali, the centerpiece being normal at 7.4. You don't need any compensation there. Uh, Above and to the left, obviously, will be acidosis, and below and to the right will be alkalosis of various kinds, and two metabolic ones and two respiratory ones, both acute and chronic. This is a nice, quick way of diagnosing patients in a busy OPD, in a busy schedule, and it's used very handily. Oh, and these are the references. Thank you very much. Lecture number 3 should follow this particular lecture. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh.